Okay. Okay, Riddhi, let's start.
Good evening to all. On the occasion of the fine meat case discussion, I am presenting the case of 66 years male presented with the chief complaint of the paresthesias of the both lower limbs for last 2 years, difficulty in climbing stairs for 11 months, walking difficulty 8 months, and the paresthesias in the hands bilaterally for the last 6 months.
Fine. So I think Riddhi, stop here. And let's sort of ask whoever wants to take. Daneshwar wants to start off?
Yes, sir, I will try.
Yeah. See, basically, I think it's a good idea to start thinking as the symptoms start coming. So whatever information Riddhi has given us, try and analyze it. Try and analyze the chief complaints.
Yes,
See,
sir.
we've got two, as we all know, just to reiterate, we've got two simple questions to answer. Where is the lesion and what is the lesion? That is all clinical neurology is about. Right, so start.
Sir, we have here 66-year-old male who is elderly and 2 years history of progressive sensory motor symptom. To have started with the sensory complaint in the lower limb distally and then progress over to the upper limb. And he has a weakness distal as well as proximal. So sensory motor syndrome is started with the sensory. So I will have to keep the localization wise. It is for the nerve as well as a root. For the nerve, he has symptoms started distally then the proximally, and he has a proximal weakness. To keep it as a root as a localization. Second possibility, involve long duration of the course. Even though I will have to keep the neuropathy as the second differential, even the advanced neuropathy can have the proximal weakness. Third possibility, I will have to keep the, assuming I am this weakness is sir, is it weakness for the symmetrical or it is asymmetrical?
Yeah, I think that's something that she will tell us later on. But
okay, so,
what's available?
So, third possibility, I will have to keep the plexus. Point favoring for the plexus is a sensory motor symptom, but odd point for the plexus patient. Generally, symmetry will be the odd for the plexus. Generally, it will be the asymmetry. Third possibility, I will have to keep.
Daneshwar, not only symmetry, bilaterality itself.
Yeah, sir.
Bilaterality itself is not common for plexopathies.
Yeah, sir.
Name some plexopathies. Name some plexopathies.
Sir, diabetic lumbosacroplexopathy.
Right.
We can have the idiopathic, like the Person's Turner syndrome plexopathy. Neoplastic, we can have the lumbosacroplexopathy.
Yes. So you will see immediately that most of the plexopathies are unilateral.
Yes.
It doesn't mean that they cannot be bilateral plexopathies. You see them from time to time. But whenever you have a bilateral syndrome, the localization of plexus becomes much lower down.
Yes.
I think that's very good. You discussed roots, you discussed nerve, and then you discussed plexus. Now, Swati, you have any other thoughts? You want to say anything?
So just, it's a chronic progressive lesion localizing to the roots and a polyradiculopathy because of the proximal involvement.
Right. So you will go for the roots. Okay.
Yes, sir.
Right. Now, I am a little curious as to what is this walking difficulty. She will tell us more about what is the walking difficulty, but I can't localize that symptom because walking difficulty can come anywhere from a myopathy right up to the frontal lobes. So that's a symptom that has a very wide differential diagnosis. Now, just let's focus on one other thing before we move ahead. There are paresthesia in the hands for last 6 months. So what are your comments on that, Swati?
So for 6 months, having paresthesias could mean there could be various differentials for the same. There could be, like with further history, whether the paresthesias are acute, whether they are present all the time or
Daneshwar, you want to say something?
So yeah, if a patient has a paresthesia, that means the patient has some sensory component element. It could be If it is predominantly burning type of sensation that is not elaborative particularly, that means it is involvement of the small fiber. If it have been associated JPS impairment or the proprioception loss, it could be affection of the large fiber involvement. It can be localized to the peripheral nerve, it can be localized to the dorsal root ganglia, it can be localized to the posterior column of the spinal cord. So I need additional history to localize it precisely. It does patient will have that.
I mean, just as a broad comment, paresthesias can come from any type of fiber. It doesn't so specifically go to small or large. It's a broad symptom. You can get it in any type of a sensory fiber involvement. But the fact that somebody is put in the Q&A or chat, the person thinks, Dr. I forget the name, that it's a length dependent neuropathy. That's what a participant has put in. So what do you think of that?
So length dependent would start from the distal, more lower limbs than upper limbs, and then progress upwards.
Right.
Length dependent why? Because he first had paresthesias in the lower limbs,
First of all,
and then
Swati, tell me, do you agree that this is a length
yes.
dependent process? And what are your justifications for that?
So the definition of length dependent, as per the description, is because in this case he first started having paresthesias of the lower limbs, and then he had weakness of the proximal lower limbs. And by the time he had weakness of the proximal lower limbs, he started having paresthesias of the hands. So that
Okay.
is a classical description of length dependent. That by the time the patient develops proximal motor symptoms, he starts having sensory symptoms in the upper limbs.
Okay. Does Naneshwar agree with this? Does Riddhi agree with this? Or you have any
No,
other
sir, I am
thoughts?
not fully agree. It is a length dependent as it has been not mentioned either it in the lower limb started distally or the proximally. One thing for the normal to have the length dependent, generally it says it starts with the lower limb distally as it reaches to the knee. Symptoms should be started in the upper limbs.
That's right.
So in the lower
Very
limb,
good.
it is not
Very
mentioned.
good. Very good. See, by the time the symptoms come to mid shin or a little above that, the hand symptoms start. Because the length of the hand and length of the legs, that much is the difference. So you're absolutely right. I don't entirely think this is length dependent because the thighs became weaker before the hand symptoms came. That I'm not very happy with. Barring that, I think everything is okay for a length dependent process. So I think, Swati, we will consider both at this point in time.
Yes.
Becoming weak in the thighs before the arm symptoms starting is a little odd. Right. So with these chief symptoms, what are our localizations? That it could be a radiculopathy, it could be a neuropathy, it could be a radiculoneuropathy, because quite a few are like that. Quite a few are like that. And right. So Riddhi, you want to tell us, you want to say anything about this, Riddhi, or you want to go ahead and tell us the ODP?
I'm agreeing with all them.
Yeah.
I'm going with the
Okay. Right.
so
Anyway,
patient was
just before we go ahead, can someone tell me what is this principle of length dependency? Riddhi, you want to tell? What is length dependency?
the
And
large
why does it come about?
so large fibers are involved. So the length of lower limb fibers and like the distance from the spinal cord to the sole and the distance from the spinal cord to the hands. So uh, till the mid till the neuropathy symptoms comes to the mid shaft, it used to affect the this hands and the just midriff area also. So
Okay.
the anterior intercostal nerves are also affected.
Okay.
So
Let
still the
me let me put this question slightly differently. What nourishes the axon. How does axon get its nourishment?
Vasa nervosum and the myelin sheath and the vasa nervosum are there. So
Mhm. What is axonal transport? That's right. Somebody has written here in the question and answers that axonal transport is affected. See, the cell body, in the case of motor, the anterior horn cell, in the case of sensory, the dorsal root ganglion, they, through the axonal process, send down the nutrients down the axon. Then towards the end of the axon, the nutrients reach there, they turn back, and all the waste products start coming back by the reverse axonal transport, and then they go to the cell body. So if you imagine, imagine the sciatic nerve. What is the length of the sciatic nerve in a full-grown adult male? It's about 45 centimeters. And how thin is a single axon? Very, very thin. No? Very, very thin. So just imagine that for the axonal transport to effectively take down nutrients 45 centimeters, turn around and bring back all the waste products back to the neuron is a physically very taxing process. So longer the axon, more likely that the terminal portion of the axon will suffer. What it will suffer in which diseases? Toxic, deficiency, and metabolic. So the principle of length dependency says that the longer axon will be affected first, and therefore lower limbs are affected first, and therefore both lower limbs are affected at the same time, and therefore the symptoms start in soles, and then they creep centripetally, and then they come up to the fingertips, and that way they go. As they keep on going, they can come up to the face also, the muzzle area, the tip of the tongue, like that. So by saying that you are looking at a length dependent process, you are implying that you are looking at an axonopathy. And you're also implying that very likely the etiology will be toxic, metabolic, or deficiency, by and large. So see, the implications are big. So you have to be very sure that it's a length dependent process. In this patient, I am still not sure. It's lower limb first, then upper limb, distal to proximal, but the sequence is not looking still all right. Yeah. So principle of length dependency, if you think it is like that, then you jump 2 steps. You have said it's an axonopathy, and you have said the probable etiology. So you're really gone very advanced in that case. Right. Okay, so let's come to the ODP. There's a lot more for us to understand. Right, Riddhi, tell us about the ODP.
Patient was apparently well before 2 years, and he noticed paresthesias in the both soles, which was gradually progressed up to extend up to the mid calves with occasional slippage of slippers. He could not feel the ground properly, and from 11 months back, he started noticing upsquatting difficulty. He noticed difficulty in getting up from the ground, and he needed to push his body off the ground, and climbing stairs was difficult. So from last 8 months, he had walking difficulty. That was imbalance while walking, more in the evening. Was present, ataxia was present. He also started noticing difficulty in wearing as well as the holding the chappals while walking. During the same time, he also had difficulty in the lifting the feet, that was left more than right while walking, and used to lift his legs high up the ground while walking. And for the paresthesias of the both hands was for last 6 months. Buttoning, unbuttoning, and the weight lifting was difficult for around 4 months, and the grip was becoming weak for 4 months, and occasionally slippage of objects from the hands.
Right. Okay. You have anything more in the ODP? Yeah. Oh, that's it. Okay. You have more in the ODP, Riddhi? No. That one slide. No, fine. So keep that slide on. So Swati, tell us what has the ODP added?
Sir, we can say that in addition to small fiber paresthesia, So the patient has paresthesia, which is indicative of small fiber neuropathy. And the fact that,
like I told you, it's not that specific.
yes,
It can be any fiber. Yeah.
yes. And the patient has difficulty in walking. First, up squatting difficulty, which shows there is some root radiculopathy. And also the patient has difficulty in walking. So there is a large fiber involvement as well. Some large fiber involvement.
Right.
Imbalance. So large fiber dorsal.
So it's given you a little idea as to which structures, which sort of fibers may be affected. Any more idea it has given you? Now, if I ask a question at this point in time, why is this not a cervical myelopathy?
So the patient,
distal upper limbs, proximal and distal lower limbs. Why is it not a low cervical myelopathy?
the patient doesn't have any radiating symptoms. One.
Okay.
Then,
so you're going by the dictum, nerves tingle and roots cry. That's, if you open up the Brain's textbook a few editions earlier, you will see this footnote. Nerves tingle and roots cry. So there are no radicular pains here. All right. What else?
there's no truncal involvement in this case, which goes against spinal cord. If spinal cord is involved, some truncal symptoms might be seen.
Okay. See, in neurology, when there are some things, when they are present, they tell you something, but the absence doesn't tell you anything.
And the fact that the symptoms started in the lower limbs first, and not in the.
Well, can't myelopathy start with stiffness of the lower limbs? It can very much start, no? So I think at this point in time, I would also consider a low cervical myelopathy in the differential diagnosis. When we see the signs, we will be able to say more. But the whole idea is to think wider, think broader, and then put things in perspective. Yeah. Okay. So you want to go ahead. Also, let me say one more thing, that there are conditions which will affect the cord and the nerve, or cord and the root and the nerve. And then the lower motor neuron always supersedes the upper motor neuron to an extent. So give me an example of a myeloneuropathy.
Subacute combined degeneration.
B12 deficiency, yeah.
Then adrenomyeloneuropathy.
Very nice.
Then
there are many actually, but yeah, I think that's fine. So that's to make us aware that there are these sets of conditions which will give you cord and the nerve, or cord and the root. Therefore, the pathology may be in more than one place. Right. Okay, you want to go ahead, Riddhi? Yeah. So
No
now
history
come the
suggests.
no history. Okay. Now see, no history is a very important part of the way you narrate. And since we here on Thursdays are for practical exam training and the practical training in DM and DNB, there are sets of examiners who will want you to say all the no's that are necessary. And there are others who will say, oh, don't give me a list of 30 no's. Just tell me 4 or 5 which you're going to tell me, which are important in your differential diagnosis. So be prepared for either. You can have these different sets of people. You know, I belong to the latter. I want to know how you have arranged it. How you arrange the nose. See, there are 2 ways of arranging it. One is to go anatomically or etiologically and go one by one and cover everything. That gives a certain degree of completeness to your presentation. The other is to get to the bullseye and say what is most relevant. So Riddhi, which way you want to do it?
Sir, first I would like to rule out the all anatomical.
All. That's
Then
safer.
after,
That's safer. Good. Go ahead.
so no history suggestive of bowel bladder and the purple weakness, double vision, drooping of eyelids or the hearing loss, no any associated fasciculations or the twitching in the any muscles, stiffness in any limbs or the tremors, no any fasciculations, no wasting, no any history suggestive of systemic symptoms, fever, weight loss or the joint pains, breathlessness on exertion or lying down and the palpitations.
Right.
No history suggestive of any autonomic disturbance also.
Okay. Fine. So which autonomic symptoms did you ask for? Which are the common ones that you see in clinical practice?
Sir, orthostatic hypotension, then
That's the commonest.
pre-syncope,
Correct.
then abnormal sweating and
Yes.
bowel bladder disturbances.
Impotence and sexual dysfunction. These three are actually seen in practice. Any can be seen depending on sympathetic and parasympathetic, but these three are common. Correct.
Even resting tachycardias.
Oh yeah. Oh yeah.
Have been mentioned that
Oh yeah, absolutely. And I have seen it in patients with porphyria.
Yes.
For some funny reason, I have seen a lot of porphyria, and they all have tachycardia. Tachycardia, hypertension, and low sodium. That's the triad of porphyria. Yeah, you're absolutely right. Resting tachycardia. Yeah. Right. Then.
Constipation.
Yeah. That's okay about autonomic. These are the three common ones. Then next.
That is all about negative history.
Right. Okay. So should we spend more time here or should we go ahead? I think we should probably go ahead. My general concept of these negative points is that you should pick up one method, either going by anatomy and etiology and complete it, or go by the most relevant ones, whichever you choose. But different examiners will want you to do it differently. So be prepared for either. Right. Then I am a little curious. Why did you ask for systemic symptoms?
Sir, to rule out the secondary causes for the peripheral neuropathy.
Like which one?
Um,
Tumors, you mean?
yes,
Infections or tumors? So which
toxins.
infection? The fever, you said fever, weight loss, joint pains.
Yes. That is maybe due to the autoimmune conditions, ANCA-associated vasculitis
Vasculitic.
or
Okay, fine. Right, then next.
For the personal history is mixed diet, tobacco chewer, occasional alcohol consumption, and non-smoker. And bowel bladder is normal, appetite normal, sleep is normal. Family history is negative, and medical history he is diabetic for 3 years only and on oral hypoglycemic agents.
Now see, in history of peripheral neuropathy, these parts are very, very important. The diet, all the medicines that the patient is taking. If you have a patient with a peripheral neuropathy, take out his drug box, look at all the drugs that he's taking, because a whole lot of medicines can result in a neuropathy. And sometimes till you open the drug box, you never know what drugs the patient is taking. So Dhaneshwar, which drug-induced neuropathies have you come across in your practice besides cancer?
Most commonly with the antituberculous, like the INS, linezolide, and if sometimes the high dose of pyridoxine was here. And second most common will be the anti-HIV drug. These are particularly common culprit for the current scenario causing the neuropathy.
Right. Amongst anti-TB drugs, all can cause, but linezolide causes a particularly severe neuropathy, which takes a long time to recover. And the HIV neuropathy that you have seen is what type of neuropathy? HIV, heart, and other drug related? It's usually a small
Sir,
fiber.
drug related will be the most common sensory motor neuropathy.
Small fiber, small fiber
And
sensory
HIV
neuropathy.
itself and cancer.
Yeah. The drug related neuropathy in HIV is a distal sensory dysesthetic neuropathy, quite like early diabetic neuropathy. Yeah. Okay. So focus on the personal history, focus on the drug history. Very, very important. And in family history, what do you ask? Riddhi, when you said family history is negative, what did you ask?
Sir, any history of similar complaints, then any skeleton abnormalities, and history of any other
You
neurological
mean
symptoms.
pes cavus, kyphoscoliosis. Yeah. See, in a lot of families, mild pes cavus goes on, but they don't think it to be abnormal. In my practice, I have come across this again and again. You show them that, oh, look, your feet are not normal, they are different. You say, they are different. In our family, it is like that. They don't consider it as abnormal. They may not even tell you. So you have to actually dig it out. So skeletal abnormalities. What else in family history?
Any mental retardation or leukodystrophy related neuropathies.
Okay. Okay.
Facial palsies, we should.
HNPP. So wrist drop, foot drop.
Yes.
Yeah. Okay. So family history is another important part of peripheral neuropathy story. You have to draw the family tree, dig into it. For that matter, actually, any neurological case, one of the basic question is inherited versus acquired. So go into the family history with some strength. All right. So what's your comment, Swati, on this diabetes?
Uh,
You
so the
think diabetes
patient,
can do this?
the patient has been symptomatic since. Yes, sir. It can be
Yeah. How
that he
often?
has proximal.
But
Yes,
you have any more comments? Yes, it can, but rarely, commonly. Do you see a
um,
proximal lower limb and upper limb problem in diabetes?
so more than proximal lower limb in Bruns-Carlin syndrome, it can happen.
You
But
know,
it will be painful. It will be
yeah.
painful.
When I was in Grant Medical College and doing the undergraduate classes, I used to give them two rules of thumb. If the hands are affected, it's more than diabetes. If the thighs are affected, it is more than diabetes. Of course, it doesn't necessarily stand for a DM neurology class because you know that there can be diabetic amyotrophy, diabetic plexopathy, and what have you. But the rule of thumb is in any patient who has an upper limb neuropathy and a thigh weakness, you be aware there will be something more. So here my comment will be that even though it is possible that a person is more susceptible to early diabetic process, some diabetics do get it in 3 years. But these 2 points tell me that I have to be careful. It won't be only diabetic. Would you agree with that?
Yes, sir.
Yeah, I think those are the rules of thumb. Okay, then next, Riddhi.
Summarize the case. It's a chronic, gradually progressive, symmetric, but the mild asymmetry was there in the foot. So, but more or large, it's symmetric, motor, distal more than semidistal more than proximal, plus sensory involvement, lower limbs more than upper limbs without bowel bladder involvement or the vesting or the fasciculations.
Yeah. So Dhaneshwar, in a neuropathy case, asymmetry tells you what? Now here it's a very mild asymmetry. It's largely a symmetric syndrome. But asymmetry tells you what?
So generally, asymmetry seen in the particularly like etiology, it can predict one thing will be the etiology.
Like
like vasculitic neuropathy will be the asymmetry. Like
What do you mean? Mononeuritis
mononeuritis
multiplex or whatever
multiplex
etiology. Correct?
will be the asymmetry.
Correct.
And
And
and generally the immunomediated disorder generally start with the symmetrical. Those who are the acquired of the like those who are the metabolic disease generally will have the symmetrical affections.
and see, one end you said quite rightly, mononeuritis multiplex due to whatever cause. And second is a radiculoneuropathy. So those are the two common reasons why neuropathies are asymmetrical. Right. So here, Riddhi, are you going to put much on the asymmetry, or you think it's largely a symmetric syndrome?
Sir, to me, it's looking more of symmetrical, but still, I would like to examine the patient and confirm my findings.
That's right. Now, let me make another point here. When you have something that started asymmetrical and became symmetrical, go to the origin and find out how it started. If you want to dig out a mononeuritis multiplex from a case of what looks like a polyneuropathy, you have to go back to how it started. And a patient may tell you there was one finger, and then there were two fingers, then the whole hand, and then very quickly everything. But when you ask him, what's your problem? He'll say both hands and both legs have a problem. So when you're trying to see, to separate mononeuritis multiplex from peripheral neuropathy, go to the origin. How did it start? So if you, in this patient, go to the origin, then you will know what is the real meaning of this apparent asymmetry. Is there anything there, how it started?
Sir, it started more or less symmetrically only, but
Nice. So we're not going to put much on that.
yes.
Yeah. Okay. Fine. Right. Okay. So what is our anatomical localization at this point in time? These are the two questions that we are trying to answer all the time.
So at this point, I will have to keep the myeloradicular polyneuropathy will be the first localization.
Okay. What is the evidence of myelopathy, or why are you thinking of myelopathy?
Sorry, I am not myelo. Polyradicular neuropathy will be the first
Very
localization.
good. Very good. I think this very likely this could be a radiculoneuropathy. And let's make a point here that neuropathy, radiculopathy, plexopathy are man-made divisions. They are not natural divisions. So diseases will overlap. You will have a radiculoplexopathy, a plexoneuropathy, things like that, because these we have made for our structuring. So yes, radiculoneuropathy. And what sort of etiology are you thinking in a 66-year-old man with a 2-year history?
So in the polyradicular neuropathy, I am thinking over the as a disease, almost 2 years of illness, so more like the chronic CIDP sort of thing. So normally it could be the idiopathic CIDP, but as age is a little bit higher, normally for the idiopathic CIDP, age will be the 5th and 6th decade. This patient is almost in the mid of the 7th decade. So secondary causes I would like to particularly rule out, particularly at this age. Paraproteinemias I would like to rule out, and the other sort of thing like though there is no history of high risk sexual behavior, fever, weight loss. Secondary things like the HIV, as it is in male, again it is little bit odd, but possibility like the autoimmune, particularly SLE, and as it is early Hodgkin's lymphoma, particularly is commonly associated with the CIDP. So this sort of thing I would like to rule out. And
Very
diabetic itself is one of the common comorbid and associated condition with the CIDP.
Very nice. So you are thinking of demyelinating neuropathies of various types here. Okay, so Swati, one question for you. In the history, what do you want to know really, which strongly favors you that, okay, this could be a CIDP? What will you actively ask?
Need some extra questions. So
No,
what
see,
goes in favor?
there is somebody here whom we think 2 years has a CIDP. You say, okay, you ask yourself, oh, could this be CIDP? Let me ask him more. And you ask something which really tells you, oh, okay, this could be CIDP. Somebody's answered it in the Q&A. Very nice. You're all brilliant people, huh?
The facial and the
any
neck muscle weakness.
You know, ups and downs.
history of relaxing.
Ups and
Relaxing.
downs. If you find something that improves for a few days, if somebody says, oh, no, for these 2 months, I was much better, doctor. I didn't do anything. I took vitamins, but for these 2 months, I was much better. And again, it went down. Then you really know that this could very likely be a demyelinating neuropathy. Which other things fluctuate? Yeah, unfortunately, medicine is never very simple, even though it is very simple. So what else fluctuates?
Sir, my neuromuscular junction disorder fluctuates.
Okay, and amongst neuropathies?
Sir, metabolic will have the relapsing remitting cause.
Metabolic can fluctuate. Toxic can fluctuate,
Yes.
depending on how they are. So somebody's asked a question, could this be a toxic neuropathy? Based on the history, could this be a toxic neuropathy?
Sir, generally toxic neuropathy will be the painful neuropathy, and these are generally lane-dependent neuropathy. So as it is, as per after the detailed history, it look like more to the non-lane-dependent neuropathy. So that is little bit off for the toxic neuropathy.
Quite right. Quite right. Yeah. Toxic neuropathies need to be considered, but lower down here. And they are dysesthetic neuropathies. People are very troubled by the dysesthesia. Riddhi, do you remember that thallium fellow?
Yes, sir.
Or was he before your time? I mean, he couldn't sleep. He couldn't sleep. Yeah. Okay. Great. So let's go to examination.
Sir, one small thing.
Yes,
Just
sir.
need some comments on this patient hand symptoms. You know, the paresthesia sensory complaints in the hands.
Yes.
Now, sir, hand sensory complaints, even, I mean, it's not very common to get even in patients of length dependent or the non-length dependent neuropathies. Hand symptoms will often indicate a cord lesion or a posterior column cord lesion. What do you think? Is it common in patients of neuropathies, hand sensory complaints, symmetrical?
I am a little more liberal on that. I think all these pathologies can cause it. But if you see a large fiber in the hands, compression of the cord definitely comes as one of the differential diagnoses.
Yes.
Like you see the high cervical cord problems.
Yes.
You know, they have pseudoarthroid movements in the hands. So, yeah, maybe I look at it that way, but I think all these etiologies can do that.
Yeah. Yes.
From carpal tunnel. Yeah.
Sure, sir.
Yeah. Yeah, Riddhi?
Yes, sir. So on examination, vital is stable, conscious, alert, cooperative, orientation normal, single breath count is normal, chest expansion is normal, no vesting or the fasciculations, hypertrophy of the ulnar and the common peroneal nerves detected, skull spine normal, no scoliosis or the pes cavus. On cranial nerve examination,
They just go back to the hypertrophy. You mean some nerves were thickened, ulnar and common peroneal nerve thickened. So Swati, give us a list of thicker nerves.
Yes, sir. So there can be hereditary causes like hereditary sensory motor neuropathy.
Let me slightly put this question. Let me add a little caveat to this question. Tell me the differential diagnosis in the order of commonness.
So leprosy.
Very good. Very good. Very good. See, all said and done, leprosy hasn't gone away. Leprosy is very much there. And leprosy is still one of the most common causes of hypertrophic neuropathy. It's sad to sort of say this. And whatever our people say that new cases are few and blah, blah, blah. One student in JJ could get 150 new neuropathic cases in 6 months of collection period of his DM thesis. So yes, leprosy is the most common. Then?
So then CIDP.
Yes.
Chronic. Then amyloidosis, acromegaly, multifocal motor neuropathy.
I think
reference
HMSN
disease.
you had mentioned, which you just now didn't
Yes, sir.
mention, but you
HMS.
started off with
Yes, sir.
HMSN. Yeah.
Yes, HMS.
So it's actually leprosy,
HMS.
HMSN, CIDP. For practical purposes, these are the three causes of thickened nerves in practice. Whatever else is uncommon, and that is amyloidosis. Often people say neurofibromatosis. I don't know why they say that. But yeah. Okay. So which of the three you think it is? Is it leprosy?
No, sir. At this juncture, I would say CIDP would be
Okay. Why not
more
leprosy?
of
Why not leprosy? It's so common, we said.
some more. He has motor symptoms.
Or you mean leprosy doesn't
No,
take
no,
motor? Arey,
no, sir.
deformities तो होते ही है ना.
Yes.
If you look at advanced leprosy, it is motor, sensory motor. Commonly, leprosy involves the temperature sense, involves the small fibers, involves the superficial nerves. So going up to thighs, making thighs weak is very unusual, unless some unusual form of leprosy neuropathy is coming. No?
Yes.
Right. Skull and spine was normal. You looked at the pes cavus very carefully, Riddhi. Yeah. Then?
So cranial nerve examination, visual acuity, color vision is normal, fundus normal, extraocular movements are normal, no facial weakness, hearing loss, hearing is normal, speech normal.
You know, Riddhi, there is one comment that leprosy should be asymmetric. So let me just explain it before you go on. Sorry to break your rhythm. See, leprosy on the TT and BT side is classically asymmetric, mononeuropathy, or mononeuritis multiplex. And that is what is the conventional teaching. Dhaneshwar and Swati, you have seen a lot of leprosy in KEM. KEM you must have seen. Just Slok you may not have seen that much.
One case I've seen, so one case.
Yeah. A lot of leprosy you have seen, Dhaneshwar, in your OPDs? KEM OPDs?
3-4 cases still now. The residency during it.
Achha. Okay. So it's basically mononeuritis multiplex or mononeuropathy on the TT and BT side. But when you come to the LL and BL side and add reactions to it, it can be a symmetric neuropathy. So a symmetric pansensory neuropathy is not incompatible with leprosy. And in a collection of some 300 cases, we published 14 patients who had a pansensory symmetric sensory motor neuropathy from the beginning. So it's possible. Since there was a question, I thought I'll say about that. The general comment that leprosy should be asymmetrical is true in terms of prevalence, because in terms of prevalence, TT and BT is far more common. But if you have a BL, LL in reaction state, it's symmetric. So that's something to remember. Yeah. Right. Go ahead.
So cranial nerve examination is normal. For the motor examination, the shoulder muscles, shoulder movements, all adduction.
So let's take this question. One second. So Swati, which cranial nerves are you interested in a neuropathy case?
The most commonly.
Which cranial nerves and why? Very quickly generate.
Yes, sir.
Yeah.
So, sir, different cranial nerves, but most commonly seventh nerve, bifacial involvement.
How does it add?
Sir, so not in, you mean in this case or otherwise?
No. In a case of peripheral neuropathy,
yes, sir.
Which
So,
cranial nerves are you interested in and why?
Sir, seventh nerve, if there is bifacial seventh nerve involvement, we will think of differentials like AIDP, Lyme's disease, or sarcoidosis.
Okay.
If there is ophthalmoplegia, third, fourth, and sixth cranial nerve, we may think of.
The same goes for eighth nerve. sarcoidosis.
Yes.
Yeah. Then
So
what
then,
about second nerve? What about second nerve?
sir, if we see on fundoscopy, if we see optic atrophy, that can be seen in drug-induced, especially ethambutol or cisplatin-induced
Drug
neuropathy.
induced
Yes.
and
So then B12 also, alcoholic and B12.
B12, yes, and
Uh,
alcohol, yes, and
some hereditary neuropathies also have
which
secondary.
neuropathies?
So some hereditary neuropathies
Okay,
can have secondary.
and the group of leukodystrophies. Leukodystrophies can have.
Yes.
Yeah. So second nerve is important. Also lupus and autoimmune. So second nerve and peripheral nerve, lot of differential diagnosis. Right. Okay. Fine. So let's go ahead. So cranial nerves here didn't give any clue. Fine. Then
So on the motor nerve examination, power on the shoulder muscles is around 4. The elbow there is 4, and the wrist is also 4. All extension, flexion, adduction, abduction. Small muscles of the hands are weak, and the grip is weak. So the hip also, the flexion extension is 3, and the adduction is also 3, and abduction on the right side is 2. Otherwise all muscles are 3, and knee flexion is 2, and extension is 3. The ankle plantar flexion is 2, and on the left side it is 1, and dorsiflexion is 3, and EHL was weak. So here the ankle plantar
so
flexion is weak.
so let's ask Dhaneshwar, how do you interpret this motor system finding?
So in the motor examination, we see the generally it is a more or less symmetrical environment is there bilateral. Upper limb, lower limb is affected much more than the upper limb. In the lower limb also, we can see the patient has a distally as well as proximally more or less there is hardly 1 grade difference. So that doesn't add much. So he has a
Yeah,
proximal
that's
lower
right.
limb
But
affecting more than the
the
upper
other
limb.
way of putting this will be that the proximal is also severely affected.
Yes.
Right. Okay. And there is a somewhat asymmetry in some actions, but it's largely symmetrical. Okay. So what does it tell you? What does this motor system examination tell you? It probably slightly strengthens your view that it is a probably not an axonopathy and it could be a demyelinating process. Now, somebody is asked a question, what is the best way of testing muscles in peripheral nerve? So let me answer that question. It basically depends on your case as to what are you looking at. If you're trying to tease out nerve from nerve, like ulnar from median, ulnar from and median from radial, then you do every muscle. If you are not going to look at individual mononeuropathies, then you can look at them as bulk. Like here, she's put down proximal and distal, both are affected. So it tells you that it's a neuropathy of sorts. Then, right. Go ahead.
Tone is decrease in all 4 limbs. Neck, flexor, and the extensor muscles are 4/5. Abdominal muscle weakness is present. So the triceps supinator, knee, and the ankle is absent, and biceps is coming with the centrasic maneuver.
Okay. So you have added that um, there was a proximal loss in the trunk.
Yes.
Yeah. So what does it mean, Swati?
Proximal loss in the trunk would suggest some cord involvement.
Or very
But
proximal roots.
yes, or
Very
proximal roots.
proximal roots. Yeah. Okay. Then go ahead. Yeah.
So pain, temperature, and touch is decreased in up to the mid calves bilaterally. That is graded sensory loss, and in the hands that is also like stocking and the glove distribution of the sensory loss is present. JPS is absent in all toes bilaterally. Vibration absent till the ankle and in the upper limb. JPS is absent in the all fingers and all distal interphalangeal joints, and the vibrations are absent.
Now, let me make a quick point here. Since we're coming close to 9:25, let's probably speed up a little. See, whenever you are seeing a glove and stocking type of a problem, like Riddhi has drawn here very nicely, please look at the upper border of the glove and the stocking. Because the upper border will tell you, if it's very nice and round, then you are likely to find an axonopathy. If it is one sliver going here, one sliver going there, one side being more than the other, then that would be a demyelinating neuropathy. So I think in a glove stocking pattern, look at the upper border of the glove and the stocking. Now here, did you get a chance to look at that, Riddhi, or the case, probably no? It's good to check that, because that tells you, when all of you, when you go back to your next diabetic patient with a diabetic neuropathy, check the upper border of the sensory loss, and next time tell me what you find. You will be surprised, because I think very few people check that. Right. Then go ahead, Riddhi. Which modalities are affected? JPS, all
JPS
toes, vibration.
all.
Yeah. Okay. Fine. Then.
So Romberg was positive, cerebellar examination is normal, and plantars bilaterally moved.
Okay. Fine. So at the end of examination.
So to summarize the case, chronic gradually progressive, motor plus sensory involvement. Motor involvement is distal plus proximal, lower limbs more than upper limbs without bowel bladder involvement or the vesting, and fasciculations with generalized areflexia.
Okay. So anatomical localization.
So it's looking like
So
a
who
radical.
will, yeah, who will take? Riddhi, you will tell? You tell. Yeah. Now examination is over, so you can tell.
It's looking like sir radiculoneuropathy and
Right.
chronic.
Now, somebody has asked a question here, which we can take at this point in time. How does one differentiate a neuronopathy from a neuropathy? Swati, Dhaneshwar, Riddhi, any one of you who want to take it.
Neuronopathy is more of
Go ahead.
neuronopathy is due to the, I think, dorsal root ganglia involvement. So more of large fiber involvement. And here the neuropathy could be sensory motor, and the pseudoathetoid movements and the ataxic symptoms are more in case of the neuronopathy.
Any other comments, Swati or Dhaneshwar?
Not sure.
No? Okay. See, the real point between neuropathy and neuronopathy is the motor system. In neuronopathy, your motor system will be largely normal, and your sensory system will be devastatingly affected. So you will have a patient with gross sensory ataxia, areflexia, but when you check the power will be normal. So the key to diagnosis of neuronopathy is profound affectation of the sensory system and profound normalcy of the motor system. That is the real point. Whereas in neuropathy, it is always sensory motor in different proportions. Now, somebody has asked a very good question. There is no mention of wasting even after 2 years. So, Dhaneshwar, what do you think of that? Why is there no wasting after 2 years? or the wasting has been missed in examination? Or is it possible that there is no wasting? Swati?
Uh, Sir, because it looks like a demyelinating neuropathy. So
Right. In
wasting
general, demyelinating neuropathies
wasting is seen in axonopathy
will be
normally.
much
Yes.
less. Like 2 weeks ago, we showed a patient of MMN of 2 years duration or 2.5 years duration, and there was no wasting. So it's possible that demyelinating neuropathies do not waste away. But in axonopathies, you see wasting quite early, and within a few weeks you can see it. Examples being neuralgic amyotrophy, axonal variety of GB syndrome, where within a few weeks you can get axonal. Now, if I may just take 1 minute of your time on historic bit. You know, one of my teachers, Professor Katrak, when I was studying neurology with him, would make notes when the wasting has come. And in GBS, he had divided people who wasted very quickly vis-a-vis people who did not waste quickly. I finished my DM and became lecturer at the Grant Medical College. I said, can I take these patients out and can I analyze them? And I analyzed them. This was 1986. And we came to the conclusion on their electrophysiology that there is an axonal variety of GBS. This was before Brown and Fisby wrote about axonal GBS. But we knew it, we didn't publish it. So how important that clinical evaluation by Dr. Katrak of early wasting was, that some GBS waste, all are not wasting. So what's happening? So coming back to this case, demyelinations don't waste. So 2 years, proximal, largely symmetrical, initial little asymmetry, no wasting, areflexia, motor and sensory. I think we are probably very likely looking at a radiculoneuropathy like the CIDP. Yeah. So now what more do you want, Swati? Dhaneshwar has disappeared? Or is he
Sir,
there?
now
You're there.
yeah,
Yeah. You're
yes.
invisible.
Sir, actually,
No,
net
that's
issue
fine.
was there, so
No
I
worry, no
lost
worry, no
connection.
worry, no worry. I was joking. Yeah. So what more do you want now? This is a CIDP-like thing. What do you want now?
I would like to work up for the CIDP in the investigation. Apart from the complete blood, I would like to get the complete blood count, fasting blood sugar, SbA1c,
Okay.
serum protein electrophoresis. I would like to get
Okay.
particularly, and
I think
in the
before we go to the test, there is something that we actually didn't show you, which they will show you now.
sir, I will have to detail
Yeah.
the exam. Particularly, there was no mention for the in the general on the general examination, the
Shabash.
cutaneous examination as the
Shabash,
reason
shabash, shabash. Very good.
particularly marker
Very
to
good.
look.
That's what Riddhi is going to show you now. Riddhi, you want to show that? Yeah.
So, bilateral pitting type of pedal edema was present. White nails was there. Nails were there, and the clubbing was present, and the hyperpigmentation was there. And these are the glomerular hemangiomata was present. And on
So which conditions do you see them? Swati, which condition do you see these skin changes and the hemangiomas?
Sir, in this
Riddhi, just
case,
show those again. Show those again. The cutaneous things. Yeah. Where do you see them? Dhaneshwar, have you seen them before?
It can be seen in like parapod like polyendocrine, polyneuropathy,
That's right. They are very suggestive of the
organomegaly,
poems.
and
Very suggestive of the
Poem
poem
syndrome.
syndrome. Yeah. So this patient had darkening of the skin. This patient also had these cutaneous hemangiomas. And what else was there, Riddhi?
clubbing, pedal edema, and white nails.
Yes. So, Swati, tell me a list of dark pigmentation and neuropathy.
sir, dark pigmentation. The angiokeratomas seen in Fabry,
Hmm.
then purpura can be seen in diaglobulinemia.
Hmm.
Then
Common ones?
uh,
Commonest is B12, no? Commonest in clinical
B12, yes, sir,
practice is
knuckle
B12. Yeah. Okay.
yes,
B12,
knuckle hypertension.
Poem syndrome, of course. Then
Then uh,
sometimes vasculopathy,
yes, that's
vitamin B12 transporter deficiencies. You know, once I had gone to um, some part of South India where they showed a case where there was a boy who looked like he was very dark and he had a myeloneuropathy. And we said B12. And his mother said that he was always like this. It's not that he's newly become dark. So he turned out to have the transporter deficiency. So how long are you dark is another question between acquired and inherited. Right. And in general examination, what did he have, Riddhi?
Sir, also he was having the hepatosplenomegaly and the cervical lymphadenopathy was there, sir.
Right. Now we didn't show this earlier on, but in a neuropathy case, general examination is extremely important, and systemic examination is extremely important. Now you add liver, spleen, and the skin changes, and the lymph nodes, and what comes up? You come up with a secondary CIDP, or
second.
if the Poems syndrome, organomegaly, endocrinopathy, skin changes, and a demyelinating neuropathy. You want to show the tests, Siddhi?
Yes.
Yeah.
Hemoglobin was 11.6, total count was 6,200, ESR was 66, calcium was 7.6, and the phosphate was 4.9. Serum IgG was elevated, that was 6,000, and the serum IgA was also that was 178, and serum IgM was 71. So most of the poems related IgG and IgA are elevated. So he was having that.
Yeah. Now, Swati, what do you expect in the electrophysiology?
So I will expect um, changes of demyelination. There will be,
Okay, so what is the evidence of demyelination?
sir, temporal. Um, there will be the motor slowing of the nerve conduction velocity.
How slow should they be in demyelinating range? The so-called demyelinating range. Naneshwar, how slow should they be?
So
Velocity?
there should be less than 80% of the conduction velocity if the of lower normal limit if the CMAP amplitude is more than 80%, and
Very
it
good.
should be the less than 70% of the lower normal limit if the CMAP amplitude is less than 80% of the normal.
Very good.
And
What is temporal? Yeah.
other thing to favor the demyelination, like there should be the temporal dispersion should be
Dispersion.
there should be the increasing latency.
Yeah.
And
Yes.
the other things like there is a prolonged EFA, or it might be the absent, or the H reflex should be there.
Very
And
nice.
we can other thing also, we can see the conduction block, that again the favor for the demyelination as well as the acquired etiology.
Right. Very correct. Now, let me make a point. Within the range of demyelinating neuropathy, there are patients who have very distal demyelination, patients who have distal demyelination, patients who have proximal demyelination alone, and the common variety, which is distal and proximal demyelination. So the commonest findings will be conduction block and dispersion of various levels in various nerves. But you can get a patient in whom only there is a distal prolongation, and you can have another patient in whom only the F and H are affected. So you have to do all. And if you look at of course, the electrophysiological criteria for CIDP, there are very many, and all of them don't go hand in hand. But if you look at the EFNS criteria, they also include the very proximal and the very distal as isolated entities within the description. So usually the electrophysiology is quite clear as to what the disease is, but sometimes it can be only distal and sometimes it can be only proximal. So you have to really look at the whole segment when you're suspecting. Yeah. What next you want to show, Riddhi?
So we had done the PET-CT that was suggestive of the lytic lesions, and that was the multiple myeloma and hepatosplenomegaly was there. And bone marrow also showed the changes related to the poems.
So the
This was all about the case.
final diagnosis is a osteosclerotic myeloma with a secondary CIDP. Now, almost 50% of osteosclerotic myelomas have a CIDP. Yeah. So in a peripheral neuropathy case, general examination, cutaneous examination, a full history of the drugs that the patient is taking, the diet, and a very good family history are additional things that you look at. Now, before we finish, there are a few value of this discussion. So, Riddhi, you want to go ahead?
Yes. So,
Before Riddhi shows some more slides, are there any questions on this case that you want to ask? Because these next slides are more for your knowledge base. They're not relating to this case. So if there are any, you put them up. I'll try and answer them. Yeah, do go ahead, Riddhi. So tell us how to catch the sneaky thief. So what is this? Dhaneshwar.
So it's
and Dhaneshwar and Swati, you can alternate take this.
These are Bertonian lines seen in neuropathy caused by.
Okay, Riddhi, tell. You tell, Riddhi. Yeah.
So these are the blue lines on the gum. So it's a Burton's lines. It's suggestive of the late neuropathy.
Very good. So tell me, lead neuropathy nowadays, has anyone seen lead neuropathy? Any one of the attendees has seen lead neuropathy, or any one of you have seen lead neuropathy? Where do you get lead neuropathy?
The painter, those who are working as a painter.
See, that's the classic description. A painter keeps on painting and gets a wrist drop. That's gone. Why is it gone? Because your modern paints are acrylic. There is no lead in the paints now. The other description is of pica, where little kids, they eat the flakes of the color that has been put on the wall and they get lead from it. But that's also gone. It's all acrylic. So somebody said Ayurvedic medicine. Quite right. Ayurvedic medicines contain lead. Ayurvedic medicine contain a lot of toxins. Whatever is a bhasma is a metallic oxide. And a popular bhasma in Ayurvedic medicine is Trivanga bhasma, which is arsenic, lead, and mercury. So you get a lot of toxic neuropathy if used inappropriately. So today's modern lead is in battery workers and from use of unleaded petrol in the atmosphere. So policemen, people whose homes are next to the Broadways, these are the people who are likely to get it. But believe me, the only lead neuropathy cases that I have seen have been through inappropriate use of Ayurvedic medicine. And there was a particular medicine called dibenil, where people got the basophilic stippling and went to the hematologist, and the hematologist would send to me, and we had a series of some 12 or 13 patients on that. So lead today is battery workers, environment, and in reality, Ayurvedic medicine inappropriately used. Next one.
And so these are more of a sensory.
Motor
neuropathies. Okay.
Lead is a motor neuropathy.
But that is
largely
acute.
motor.
But that will be
Acute
more.
and chronic both.
Both will be more. Okay.
Both are largely motor.
Yeah.
Yeah.
Okay.
Acute is almost like GBS. Quite right. Yeah. Next one.
So, this is the patient came with the GBS like symptoms, and on the third week he developed this type of findings were there.
This is
So,
our fellow. Okay.
Sir, this look like to be thallium, like he has a
Excellent.
hair loss, and
Excellent. And hair loss and
sir, he has hair loss as well as some Rendu type of pigmentation of perio.
yes.
His
And
skin peeling is there, and of nail.
see, the nail has Mies lines, which are the transverse lines. You see the white. Riddhi, you want to put the cursor
Yeah.
there? Riddhi, you want to put your cursor there? Huh. See that line? That is the Mies line. So thallium is dysesthetic neuropathy with alopecia. And the alopecia comes around third week, second to third week. Next one.
So these are the patient usually used to come on the first decade and with the more of cerebellar symptoms and neuropathy is also there.
This is not our patient. This is from the net. Yeah.
Sir, it could be the nutrition division, like the Pelagrantnum syndrome like condition. Like he has ichthysis is there.
Somebody from the audience has answered Refsham's disease. What do you agree with that, Riddhi?
Yes, sir. Retinitis pigmentosa,
Yeah, I
ichthyosis,
think
cerebellar symptoms.
yeah. See, the retinitis pigmentosa is the giveaway here. It's an inherited disease. Yeah. Then
And overriding of the fourth finger is also there. Short fourth finger.
if you saw this sort of thing in the hands, what will be your diagnosis?
Hypoparathyroidism.
Excellent. Who's that? Swati.
Yes, sir.
Very good. Pseudo hypoparathyroidism. Very good. Next one.
These patients are usually come with the small fiber neuropathy, and these are the telangiectasias. Here the telangiectasias are.
This is a slightly tough one. Somebody said Fabry's disease. That's Mehul Desai. So could it be Fabry's disease, Riddhi?
Yes, sir. These are the Maltese cross crystals. These are the angiokeratomas, telangiectasia and angiokeratomas.
You know, has anyone seen Fabry's disease? Have you seen Fabry's disease? You know, where are the angiokeratomas?
So these are in
Umbilicus.
bathing area.
They are in the bathing trunk area and
behind the scrotum, sir.
Behind the scrotum. So unless you know where to look, you will not find them. Absolutely correct, Rakesh. That is where they are. Yeah. And then people have dysesthetic neuropathy, stroke-like episodes and things like that. Yeah. Then?
So
that one is not, it's not showing too well, no? Let me say, this is a patient who actually came, for some reason is not showing too well on this. This patient came to me, came to an endocrinologist because he was having too much hair on the face. And it's not showing too well, but this area, this is where he had shaved. And all this area, there was a lot of hair. And his eyebrows had joined in the 6 months before he saw me. See that? And this turned out to be another patient with Poem syndrome. So that was an unusual case. Now, what do you see on the bottom right? This boy was brought to me with walking difficulty.
Hypertrichosis.
No, hypertrichosis is here. That was the Poem fellow. This one now.
Curly hair.
Array, somebody
early.
from the audience has diagnosed it. Reshma.
Giant, giant.
Giant.
Very good. The curly hair. The curly hair. Yeah. Kinky hair disease. That's what he had. Giant axonal neuropathy. Next one.
So
Amyloidosis.
Very good. So what symptoms patients come with? Amyloid neuropathy. When do you suspect an amyloid neuropathy?
When there is a predominantly autonomic symptoms and the small fiber neuropathy, we should suspect.
Excellent. Autonomic neuropathy plus sensory motor neuropathy. One clue. Second clue. Second
They
clue is
generally
here.
start in the upper limb.
Second clue is here, Naneshwar. On the right,
They start generally in the, yes.
upper limb neuropathy. Okay.
They start in the upper limb.
Carpal tunnel syndrome in males. Somebody, 2-3 people have said CTS. That's quite right. But CTS in males. If you see a male with CTS, your ears should perk up. And change in voice. The third symptomic change in voice. The voice becomes hoarse and they get macroglossia. So carpal tunnel in the males, macroglossia, change in the voice, autonomic neuropathy are lead due to amyloidosis. And on the bottom panel, Riddhi, what have you put up?
sir, HNE stain showing the amyloid depositions around the perineurium. This is asterixis. And here the congruent, there is apple grade birefringence that is seen over the perineurium as well as endoneurium. Around the vessels also, these are amyloid deposition.
Yeah. So what is apple green birefringence? Daneshwar? What does that term mean? I think last time the histopathologist told you about it. What sort of microscope?
On the...
What microscope do you need to check that? You need the polarizing microscope. Polarizing microscope. And what is birefringence? Polarizing microscope pushes the light in a certain manner. So when the direction is at 180 degrees to each other, you will see the refringence. Therefore called birefringence. And as you can see here, the middle plate and the right plate where the arrow is, you can see the polarizing light showing the amyloidosis. The right one is on the blood vessel. Okay, then. Okay, so we're coming close to 10 o'clock and we have some constellations for you to make this clinic more useful. So Riddhi, you want to go through them? See, different within peripheral neuropathy, some guidelines to help you the etiology and this. So pure motor is?
Pure motor is related to the lead or the depsin. Multifocal motor neuropathy, diphtheria, and the motor variant of the AIDP and the in porphyria. Predominantly, that is motor. And the pure sensory, Jagran related.
Whatever porphyria I have seen, it is predominantly motor. It's not exclusively motor. Exclusively motor really is MMN and lead dapsone. Okay. Then
pure sensory is related to the Jagran sarcoidosis, thiamine deficiency, and the paraneoplastic and the HIV. Paraneoplastic and the Jagran can have the sensory neuronopathy symptoms.
That's right. So when you're talking of pure sensory, you are leaning towards neuronopathies. Right. Then?
Toxins, cisplatin and pyridoxine. And the autonomic, there is diabetic neuropathy, amyloidosis, HIV neuropathy, porphyria, and the AIDP.
Right.
Symmetrical polyneuropathies are diabetes, toxins, drugs, metabolic, and the hereditary neuropathies. They are the symmetrical one. The multifocal are the entrapment neuropathy. Entrapment is the multiple site, but for in the common practice, we have to remember the leprosy and the diabetes. Then myxedema, acromegaly, amyloidosis, and HNPP also, that is also multifocal, and vasculitis. Myeloneuropathy, B12 deficiency, that is most common. copper deficiency, HIV infections, adrenomyeloneuropathy.
Where do you see the copper deficiency? In what setting?
Sir, bariatric surgery.
That's right, bariatric surgery. That's one of the common ones. Then
Excessive use of
Excessive zinc.
Excessive zinc in dentures,
excellent. Yeah.
in elderly population.
In patient with concomitant iron deficiency anemia also produces for the copper
Yeah,
deficiency.
because
And
zinc,
when there is excessive ascorbic acid,
yeah, zinc is a competitive inhibitor of copper. No?
And
That's why you use it in.
the patients who are used who are very fond of taking multiple vitamin tablets.
Yes, yes.
Yeah.
Yeah.
COVID.
Modern all vitamins nowadays contain zinc. No,
Zinc, yeah.
yeah, that's in fashion. You know, if you have hair loss, they will give you a multivitamin with zinc in it. I don't know whether it helps or not. Right. Then
Frederick's attacks. Yes, sir.
yeah. Then go ahead. Yeah.
So Frederick's ataxia and vitamin E deficiency, and the predominantly upper limb onset is MMN, hereditary amyloid neuropathy, late neuropathy, porphyria. Porphyria, sir, it's more of proximal in upper limb.
Hmm. Actually, you know, the porphyrias that I have seen, they are generalized neuropathy with a lot of upper limb involvement. It doesn't necessarily start there, but it comes in these charts somehow. Okay.
HMS and type 2D. So these all are the clues. So that will give the that will help us to the localization of the whatever the peripheral neuropathy is there, and we have to see for the other clues also, as we had discussed, the general examination and the systemic examinations other than the neurological examination.
Great. Excellent. I think we've covered a lot today. So any questions anyone has, we are happy to answer before we close.
There are many questions for you.
Yeah.
I
So
have to
you
select a
take them,
few of them.
Rakesh, you take them.
Sir, one is that when you examine the sensory system,
Yeah.
you have to go the graded wise or dermatome wise in general.
Yeah. It basically depends upon what are you trying to gain from the examination. You know, just like in motor system, you're trying to differentiate nerve from a radical, nerve from a plexus. So you will do key examination. Similarly, in sensory system, are you looking at a mononeuropathy multiplex? Are you looking at a radiculopathy? Are you looking at a plexopathy? So you're looking at a pattern. So you're basically doing a pattern recognition. And it will entirely depend on the case that you're dealing with as to what you want to check carefully. So it's completely case-based. Wouldn't you agree with that, Rakesh?
Absolutely, sir. I mean, you
Yeah,
have
it's
to see the
case-based.
case based.
Case-based, yeah.
Then, sir, pes cavus in acquired neuropathies.
Good question. See, when there is a lot of loss of muscle on the foot can look high arched. So in acquired diseases, when you see such a wasted foot, you may get an impression that you're dealing with pes cavus. But you ask such a patient to stand and the thing flattens out. So which is the best position to examine pes cavus? Swati or Dhaneshwar or Riddhi?
we should look from the lateral side and put the
Lateral
torch
side.
below to
No,
either
what
the
should be
light
the
is lost.
patient's position?
So standing as well
Standing.
supine.
Patient should be initially sitting with his feet dangling. So you get a general idea. Then you ask them to stand. Bony pes cavus will remain. Muscular pes cavus will flatten out. So for bony pes cavus, what you told Dhaneshwar, you put a torch. In bony pes cavus, it will come. But in this so-called muscular pes cavus, the pes cavus happens in acquired diseases, by and large.
Then, sir,
Then Rakesh?
fifth nerve and neuronopathy.
Huh.
What is the
Yeah.
importance of fifth nerve?
Uh,
in neuronopathy?
Yeah. I think if you get fifth nerve in a patient of neuronopathy, the chances of Sjogren syndrome are much higher because the Sjogren syndrome patients tend to have the fifth nerve
Yeah.
involvement. Some of the paraneoplastics also have that.
Actually, sir, this. If you have fifth nerve, it practically rules out a paraneoplastic cause of neuronopathy. Is it
That's what has been written. That is strongly favors Sjogren.
favors Sjogren's?
Strongly favors Sjogren.
Yes,
Yeah.
yes.
But I'm not sure.
Yeah.
I think the trouble is when you see long enough, you see when you get more, you see everything, so you get more confused. But yeah, the statement that you say is there in most of the books that if you get fifth nerve in addition to a neuronopathy, it strongly favors Sjogren. Yeah.
Yes, sir. Then why there is no wasting in chronic demyelinating neuropathies?
Right. The theory is that the axon is intact and the primary nourishment of the muscle comes from the input that the axon is giving, the talk between the axon and the muscle. So as long as the muscle membrane has the axonal input in it, the muscles don't waste away. So that's what happens in demyelination. But as demyelinating processes go on and on and on, then secondary axonal degeneration occurs. So then they can waste.
Then, sir, the rest of the questions are all thank you for you, sir. Yeah. It's,
Right. I think we covered quite a bit today
yes, sir.
in one class.
Then, sir, Dr. Sumant is asking, but poem syndrome, mostly MGUS is involved rather than multiple
Yeah.
myeloma, and lesion
Yeah.
myeloma
Yeah.
are more likely to be
He's
sclerotic.
right. He is right. If you take, say, a cohort of patients with poems, the MGUS will be more. But myelomas can also do that. And what he's saying second is also correct. 50% of osteosclerotic myelomas will have a CIDP. But if you see CIDPs and myelomas, then they can be sclerotic as well as lytic.
Yes. There's a neuronopathy versus neuropathy. Dr. Murli is there. He's saying, yes, the most common difference will be a non-length dependent. Neuronopathies are classically non-length.
Yes, coming on the trunk
Yeah.
and sparing of the motor system.
Yes, of course, that is of course. Yes.
Yeah.
Motor system has to be spared. Yes.
Yeah, sensory, they can come on the trunk. They can be very proximal. Quite right.
Yes. That's it, sir. I think
Great.
that's
Great. So let's thank all of the participants.